you all. And it's my pleasure to welcome Professor Ravichandran to take over and conduct the entire show. Dr. Ravi.
Thank you, Shiva. Nice to see you for so many years. Very warm good evening and welcome to one and all, and respected Professor Patrick Yasudin sir, Professor Shiv Kumar, and my friends and colleagues of dermatologists. Very happy to be here today to assemble for another session, and this is going to be the Hair Research Society's meeting. And on behalf of the society today, I was asked to conduct these proceedings today and chair this session. I'm very blessed and happy to share my session. We have interesting academic, as usual, every time, every meeting, under the guidance and our philosopher teacher and guide, Professor Patrick. We learn so much, and every session is a learning session. It's not that we just come and see each other, and of course pleasantries are there. Our old photographs are still viable and live, so we love to assemble, and I think Muruk Sundaram assembled us. I think he's a group coordinator and manager. I think he always attracts us, all of us, to come for this kind of events and academic excellence. And we are very proud to have Professor Paul Divakar Yasudin here again. Last year he was here, again here. Today morning he has landed from UK. It's his tiredness. I think he says I'm comfortable. Anyway, we will have a very good session. Every time he talks about so many things, we learn so much of oral minoxidil use in our dermatology use last meeting. And we also have an array of Muruk Sundaram is here with the hair events, and then I have a small case presentation today. And on behalf of this society, I welcome you all again, and we'll proceed to start the session today. And the first topics will be the art of natural color, hair coloring, by Professor Paul Divakar Yasudin. And please, sir, he is from a consultant dermatologist. He doesn't require any introduction. He is very apt, and we always listen to everyone, Sumitra, and everyone is happy to listen to the YouTube lectures. It's excellent and awesome. And professors, of course. It's I'm just telling, virtual meeting, YouTube learning is becoming very common nowadays. And he's a consultant dermatologist lawyer, Liverpool University Hospital. Over to Paul Divakar Yasudin for his presentation. Thank you so much.
Good evening, everyone. Can you hear me? Yeah. Thank you very much for your kind words, Dr. Ravichandran. Well done to all of you to have made it. There's a big match going on in another 1 hour, and there's a French Open finals, and you've still made it. So well done to you. Even on the computer screen, I think it says the India-Pakistan match in 1 hour. So we will try and make things as interesting as possible. And the title I've given for my talk today is a bit cryptic. It's called The Art of Natural Hair Coloring. And the reason I want to talk about this is, I think there is an epidemic going on, and nobody talks about it. And the epidemic is actually very apparent for me to see from outside. It's not only here, it's the epidemic going on all over the world. And I want to talk to you about hair dyes and some of the toxicities associated with it, and what we can do to avoid some of the things that can happen with the use of hair dyes. Some of the facts with hair dyes is truly staggering. I mean, every hair dye has about 5,000 different chemicals, and if you look at it, it says here that 75% of women in the US use hair dyes, and I don't think we are much we're lagging behind very much. I think it's fairly similar in India as well. At least 75 to 80% of women will use it here. And the sales are just going up. I mean, 28 billion in 2020, closer to 30 billion, I think they're projecting in the next couple of years. there was an article in the American Academy of Dermatology, and they said that about 25% of those who use it will have some form of adverse effects. May not be very serious, it may be mild, but some form of adverse effects. And I'll be talking about a couple of them today. In the UK as well, it's very, very popular. There are both the kinds of hair dyes. Some people like to bleach it and some people like to color it darker, and both varieties. Hair dyes make up 27% of all hair cosmetics. So you can see that overall hair dyes is a universal cosmetic. It's used everywhere, all over the world. What can it do? There are a couple of things which we are well aware of. Allergic contact dermatitis, we know occurs fairly commonly. As I said, about a quarter of them. There is a possible link with cancers, and I was looking at various meta-analysis, and the one possibility is that it may be linked with non-Hodgkin's lymphoma. It's a very mild risk, but the authors suggest that if you have a family history or a personal history of lymphoma, then you're better off trying to avoid synthetic hair dyes. So that's an interesting point which I think I was not aware of when I was doing the research for this topic. The other important association with cancer is if a pregnant woman uses hair dyes, then the child is more liable to get some form of internal cancer. And again, these are very slight odds, but they are definite odds ratios. The most common condition which I think is happening, which I can see quite clearly each time I see photographs of my friends together or family members together, I can pick out at least one person who has the last one, which is pigmented contact dermatitis. So that's incredibly common, and I'm not too sure whether people miss it here or just accept that it's part of using hair dyes. So I'll talk a little bit more about pigmented hair dyes, pigmented contact dermatitis. It's a non-eczematous variation. So you don't always get eczema before you get the pigmentation. It may be so mild that you don't experience it. There may be subtle signs, as is mentioned here. And then you get this very gray pigmentation. Sometimes it can be dark, sometimes it can be light, generally in the lateral aspects of the forehead and of the cheeks, and sometimes in the helices of the ear and in the ear lobules as well. In fact, that's supposed to be a reasonable sign to tell you that you have to look for pigmented contact dermatitis, particularly if it comes to the ear lobule. There was a nice paper in the Indian Journal of Dermatology about 2 or 3 years back where they looked at pigmentation of the ears as a possible indicator of pigmented contact dermatitis from hair dyes. And these are some of the pictures. I think Sumitra also sent me quite a few pictures when I asked you last year. I haven't used those pictures, but you can clearly see that the ears are pigmented. The pigmentation is more in the lateral aspect of the face rather than in the central aspect, which is what melasma does. So it is distinct from melasma, although they say that melasma is more common in those who have pigmented contact dermatitis. But you can clearly see the central face is spared. It goes more laterally in the cheeks, almost to the jawline. Also comes on the forehead, and then the ears. That's a very good clue. Usually the top of the ears, and sometimes the ear lobules as well. In fact, there was a series by Bishnoi et al. They say that if you have ear pigmentation, ear lobule pigmentation, you have to rule out pigmented contact dermatitis. And you can get depigmentation as well, not just hyperpigmentation. It's scattered pigmentation. So in fact, I've sometimes seen a sort of reticular variant of it as well. Many times it's misdiagnosed as lichen planus pigmentosus. And I don't know if people actually ask for a history of hair dyes in this group of lichen planus pigmentosus. It actually may be hair dye induced pigmented contact dermatitis and not LPP. let's look at the mechanism as to how this could be causing it. There probably is a genetic component. It seems to be much commoner in those who have darker skin. So Asians, particularly in India, I think it's much more commonly noted. So a genetic factor meaning we have more melanin, so maybe we are more predisposed to it. There is cutaneous inflammation, and what this cutaneous inflammation does is it increases the number and the size of the melanocytes as well. They feel that some allergen, we don't know what it is. I told you there are nearly 5,000 chemicals in hair dyes. One of them possibly has an affinity for melanin, and that provokes increased melanogenesis. One thing is, people sometimes come and ask me and say, oh, I've done patch testing and it's negative. And that's often the case because the allergen is too low. It can't produce a spongiotic dermatitis. That's why you don't get eczema either. It's a low concentration, so you get increased pigment changes, but you don't get the eczema with it. And these cytolytic changes seems to be in the basal layer, and that's what causes the pigment incontinence going into the dermis, and that's why it's difficult to treat as well. Once the pigmentation goes into the dermis, it's very hard to displace it. What can be done? I'll be talking about natural hair dyes, but before that, I think we have to revise a little bit of the anatomy of the hair, because only if we understand how hair dyes work, then we will know how we can avoid this problem. The hair shaft is the shaft above the surface of the skin, and when you look at the hair at that site, it has three layers. It has the cuticle, which is the outermost layer, and that's like the stratum corneum of our skin. It's usually enucleated keratinocytes, and they form like a sheath, and they protect the hairs inside. You then have the cortex, which is bundles of keratin fibers. That's what gives you strength to the hair follicle. And you have a medulla right in the center. And we don't really know what the reason the medulla is. That doesn't seem to have any specific function. Most of the hair dyes, we have to look at the cuticle and the cortex. That's where they are concentrated. The hair color is usually because of melanin, which is in the hair cortex, which is the second layer. What hair dyes do is they do two things. One is, if you want lighter hair, it bleaches it. If you want darker hair, it adds in artificial pigment. So when you have a darker hair dye, it doesn't provoke your own melanin. These are actually chemicals which are put into your hair, and then they are oxidized to give you the dark color. So in both ways, the melanin is disrupted. So the existing melanin is compromised, and you are actually causing damage to the hair shaft the more often you use it. Hair dyes itself, there are three varieties. You have the temporary hair dyes, which is what I'll be talking about because they are natural hair dyes. They have to be replaced every few maybe after every 3 or 4 washes. You have the semi-permanent ones, which last a bit longer, and you have the permanent ones, which are the ones which are most commonly used and which are marketed by various companies. The temporary hair dyes, if you go back to the anatomy, it attaches to the cuticle on the outside, and they are very weak bonds. They are called van der Waal bonds. And because they are weak, they are electrostatic bonds, which is why they remain on the surface, but after some time, they will be washed away. They don't stay on the hair for very long. The permanent dyes, on the other hand, go into the hair cortex. And the way it goes into the hair cortex is, you have two chemicals. You have a chemical which disrupts the hair, and you have another chemical which oxidizes the colorless fluid to become colors. And that's why it goes into the cortex and stains it quite uniformly. And then finally you have the semi-permanent, which is probably a combination of both varieties. These are wonderful scanning electron microscopic pictures which show how the hair dye is deposited. If you look at the temporary hair dye, it's mainly on the outside. See, it's coating the hair sheath. It's not gone into the cortex. Whilst the permanent hair dyes, you can see how uniform it is, and it's completely pigmented the hair shaft, which is why it looks so natural. We have to look at the differences between permanent and the temporary hair dyes. I told you already that the temporary hair dyes, it gets washed off. So the permanent hair dyes are not removable by shampooing. It actually has to grow out. The temporary ones don't need chemical reactions, but this does. You have to oxidize it. And it is colorless usually. And then once you disrupt the cuticle and you put it into the hair, you then use hydrogen peroxide to develop the color. And that's why it's so uniform. It's a chemical reaction going on inside your hair shaft. It also bleaches, as I said, the pigment, and it oxidizes the colorless precursors. Unfortunately, the hair shaft sustains this oxidative damage, which is why the more we use it, the more disruptive it is for our hairs and the more careful we have to be. This is the mechanism by which PPD causes changes and allergic contact sensitivity. So PPD, once it gets into the skin, is either acetylated or oxidated. When it is acetylated, it causes monoacetyl PPD or diacetyl PPD, and these are very potent irritants, and this is what causes skin irritation, allergic contact sensitivity. Sometimes it's even absorbed into the skin and it causes acute kidney injury and rhabdomyolysis. So there are case reports of lots of hair dyes causing renal failure. So that's something we have to be aware of. It can also cause oxidation, and when PPD gets oxidated, it then starts stimulating the dendritic cells. And the dendritic cells then cause an inflammatory cascade which goes into the lymph node, and then that perpetuates the cycle of inflammatory changes. You can see that both mechanisms are not good for the skin. They both cause toxicity and they both cause inflammation of the skin. The possible solution: what can we do to avoid permanent hair dyes? Let's go for natural hair dyes. There are these natural hair dyes, and I'll talk a little bit about the first three, and there are a few more natural hair dyes. We'll look at how it can be advantages and what the disadvantages are as well. We'll talk about henna first. It's probably the most popular. It's very common in Asia, particularly in India and Pakistan. We use mehendi not only on our hair but also on our hands for marriage functions. It's from the plant Lawsonia innernis, and it's very commonly grown here. The thing is, it doesn't give you a dark color. It gives you this sort of reddish color because it's got something called naphthoquinone. That's why it can never give you the natural color which dark people with our kind of skin have. It's not that great for skin of color. There are other advantages of henna. It's supposed to strengthen and condition the hair. You can mix it with other ingredients, and I'll go into this in a bit more detail. And it stimulates hair and can treat dandruff as well. So there are some advantages of using henna. The preparation, these are all preparations which are suggested in a very good textbook on natural hair dyes, natural dyes, of which hair is one of the topics. So what they suggested is mix 1 part of henna with 2 to 3 parts of liquid, and it's preferably an acidic liquid, so lime juice or coffee which has a bit of acid so that the pH is lowered. You then make it into a yogurt-like consistency and you leave it for a few hours. If you leave it overnight, it's even better. You then divide the hair into sections and then you apply the henna. Try and make it as uniform as possible from the bottom right to the top. And then you cover it with a plastic cap, like the shower cap, and you leave it for 2 to 4 hours. You finally wash it away and you try and use a sulfate-free shampoo. In that way, there's no interaction with the henna itself. What it does give you is this sort of auburn to red-brown color. So it's not perfectly dark. It looks slightly different in our skin color, but it lasts a few weeks. Sometimes they say you may have to do a strand test, which means you take just a few strands and you try it there, make sure your skin is okay, make sure your hair is okay, and then if it's okay, you generalize it to the rest of your hair as well. The only problem with this is I've found a couple of articles which suggest that henna itself may not be that safe. So this came in 2023, and it's a big study from Korea. I think it had more than 100 people, 100 patients, much more than that. And what they found was those who use henna were also likely to get pigmented contact dermatitis just by henna alone. If you look at their abstract, it says henna users had a higher risk of pigmented contact dermatitis. And look at the odds ratio, 5.5, which is fairly significant. And then it also shows that there's an increased incidence of pigmented contact dermatitis. Again, very, very high ratios. That's adjusted ratio, 4.5 to 10. So all this suggests that not just synthetic hair dyes, but maybe even some natural hair dyes can give you pigmented contact dermatitis, particularly henna, because that's what they found in this study. And this is a picture from that study of a person who had used henna. And they've specifically said, so it's a henna hair dye user, and they've specifically looked at the distribution of the pigment. And again, you can see it's the lateral aspect of the jawline, the cheeks, and the forehead. The central area is relatively spared, a little bit of pigmentation in the ear lobule, and again, the adjacent area where the hair dye may have come into contact with the skin. Another article, this is from one of the, I think this is from IJT. So here, these are products available in India, and they have been advertised as henna. But when the investigator took this and analyzed it, it had PPD. So even though they say it is henna and it is natural, I'm afraid unless you make it yourself at home, it's going to be very hard to know if there's PPD here or not. Let's go to the next dye. It's indigo. Indigo is again fairly easy to acquire. It's a tropical and subtropical plant. It's a tree. And you get the dye from this species, Indigo tinctoria. It's from the leaves. And this is better because this color is probably slightly in tune with our skin. It's for darker tones. It gives you a brown or black color, and you can combine it with henna. So if you have henna, which gives a slightly reddish color, and this, which gives a darker color, together they give you a better blend. The only problem is it can be drying, so always use deep conditioning treatment after its use. And the other thing is, if you make indigo from the powder, try and use it immediately because it cakes after some time, so you're better off using it fresh. There are other uses as well. You can use it for graying hair. Again, there's not much treatment for graying hair yet except for dyes. And you can prevent graying of hair according to some studies. It also has antifungal and antibacterial properties, and it restores hair pH. I've told you that with the synthetic PPDs, synthetic hair dyes, the pH is actually altered quite profoundly. Here, it actually restores it and promotes hair growth. The preparation, this is again from that textbook I mentioned. They've asked us to mix indigo powder with dark water. The proportion is 1:2:3. That is 1 portion of indigo with 2 to 3 parts of water. But every natural hair dye, if you mix it with something slightly acidic, lemon juice or coffee, it opens up the sheath, the outer sheath, and therefore it's able to penetrate just that little bit deeper into the skin. You make it into a smooth paste, just like the previous henna. Leave it for 15 to 20 minutes, and then you mix it with henna and apply it on the hair. Usually, the longer you leave it on the hair, the better it is. So even though most people say 2 to 4 hours, if you leave it overnight, put a shower cap and leave it overnight, it's even better for your hair. And this is something quite recently, which I found just a few weeks ago, that coffee can give you the same color. So brewed coffee can give you shades of brown, and it also gives you that multi-toned effect. And I'll show you a picture which I got from the internet recently. Here again, I told you the acidity seems to open up the hair cuticle. So I've just done a video on this. You can have a look at it later if you want. You can brew the coffee 2 to 3 times the normal amount. stronger the coffee, the more intense the color. The darker roasts, in the UK, we are able to get these roasts, some of which look really dark. And I think if you get the darker roast, it will give you a richer color. You let it cool down, it'll again be a bit semi-solid, that yogurty consistency. And you can add a couple of extra spoons at that point if you want an even better color. And you apply it on the damp hair. Again, coffee seems to be something which is quite easily accessible. So it is worthwhile trying these simpler things if we are faced with somebody with very, very severe contact dermatitis. You apply it just like the other natural hair dyes, from the bottom of the shaft right to the ends. If you can leave it longer, it tends to work better. Finally, all the natural hair dyes, if you use a conditioner after application, it seems to stay on the hair for a bit longer. It can cause a bit of dryness and brittleness, particularly if you use it a lot, so just be careful how much you use it. What I would probably suggest to my patients is, if you want to use PPD dyes, that's fine, but maybe once every 2 or 3 times, try something natural so you're preserving your hair, particularly if you don't have anything important to do that a week or so. Try something natural, see if that helps you. Those were the pictures from the internet. I mean, if you look at it, it's reasonable color. They already have a bit of brown color, and it just gives you that darker color, and that's the sort of consistency, and that's the way to use it all over the hair. And using a shower cap would probably be beneficial as well. Finally, hibiscus. Hibiscus is the national flower of Malaysia, I believe, and that produces a natural dark purplish or magenta color, and you mix it with other hair dyes like henna. There are quite a few other hair dyes, natural hair dyes, which I won't go into. Most of them give you that sort of golden or blonde color, so it's probably not applicable to us, except maybe for amla, which gives you a dark brown color. That's the gooseberry. Beetroot and chamomile and cassia all give you a golden color. All of them are easily accessible in our shops. This was an interesting article I found. About 10 years ago it was published, and they mixed 4 different natural things. They mixed walnut bark, henna, amla, which is gooseberry, and ruby caulifloria, mangista roots. And when they mixed it, they give the formula in that particular article. They actually had really good uniform coloration of the hairs. So again, if we use these combinations, we just try various combinations, we may find one which really suits our hair very well, and it may be a natural alternatives to synthetic hair dyes. What's the advantages of natural hair dyes? It's renewable and natural, so you're not going to harm the environment. It's generally non-toxic, although we've seen that henna can sometimes cause pigmentation. And many of them have these natural properties, antimicrobial, anti-cancer, anti-inflammatory effects. So well worth trying them just for the variety of positive things it can give you. The disadvantages is it's a bit more expensive. You'll have to do it yourself. The expense, I guess, is your time. You have to spend a lot of time making it, putting it on. So the expense, I wouldn't say necessarily is monetary. It's mainly the expense of your time which takes. The color may not be that consistent sometimes, unlike synthetic hair dyes, which breaks the hair, gets in, and then diffuses uniformly. Here you're applying it from the outside, so you have to make sure that it's from the base right to the tip of the shaft. It can also fade more easily. I mean, sometimes within 2 or 3 shampoos it may go back to normal, so you may have to do it more often. And the availability also may be variable. So I hope I've sort of convinced you that maybe have a little bit of a break from hair dyes at least once in a way. You can use it if you don't have problems with it, but if there are problems, try something natural, and that certainly may be worthwhile trying. I thought I'd just tell you a little bit about a book which will be released this month, which I've written with my father and my son. It's called Dermatology in Skin of Color. That's a QR code. If you scan that, the cargo company will give you ideas we'll give you updates on when it will be released. So I'm hoping it will be released sometime this month. So please have a read if you can.
Thank you, Dr. Divakar, for a very informative and we never knew that it's a very odd topic, and you have done a good job, because we just tend to, some patients ask us, don't use that, use henna, but so much of literature you have given, and I think and we always follows the footsteps of our professor, that any patient who comes no, that's the thing for the hair colors, mind-boggling, and the pathomechanisms, and it's very nice. That hope we prescribe this to ask Murugasundaram to manufacture one.
I know.
Natural.
We need some natural hair dye.
Dye, and then distribute and sole owner in India. Thank you so much. Thank you. Next, I will be. You wanted to share your topic, or shall I proceed with my topic?
Yeah, whichever.
Yeah. You can finish your topic, no? That's the interesting hair sessions from the UK.
I've actually changed the title. I just called it Snippets from the UK, because some of them are not cases. They're just bits of information which I think you may find interesting. So quite a lot of changes in the way we treat hair conditions in the UK, particularly in the last year. So I'll try and make it interactive. Can you tell me what JAK inhibitor is licensed for use for alopecia areata in the UK? It just came 2 months ago. Baricitinib has not been. The NICE guidelines found that it was not cost effective. So we can't give baricitinib for alopecia areata. Pardon me? It's not tofacitinib either. It's not UPA either. It's actually ritlecitinib. So this is the drug which they found was had some cost effectiveness, and they based it on this Lancet article which came last year. So in this article, they looked at how ritlecitinib may be helpful for alopecia areata. Quite a big study, 118 sites in 18 countries, a really big study. And they used various doses. They used 30 milligrams, 50 milligrams. They tried a loading dose of 200 milligrams first, then went to 30 and 50. And the results were pretty good. I mean, if you look at most of the drugs for JAK inhibitors, they're not dramatic. These are people with quite extensive hair loss, at least 50% of hair loss. But if you look at the response rate, it's about 40%. I mean, now we have PASI scores of PASI 100 of 90%, 80 to 90%. So when you look at our psoriasis treatment, alopecia areata treatment doesn't seem to be that great, but at least we've got something now. Before we had nothing. At least we have something. And if you look at even the placebo effect is fairly significant here, nearly 20%. They did these various doses, and they found that 30 or 50 milligrams seemed to be the best. They tried 10, it didn't work. You can see that's the lowest. 30 and 50 are more or less the same. So 50 is the one which most people go for. They didn't find a great deal of difference with the loading dose. If you give a loading dose, it goes up quicker, but then the other modalities catch up. So that's what they found with ritlecitinib. Eyebrow hair growth was higher. It's closer to 50 to 60% compared to the rest of the hair. Remember, all of these people had really severe hair loss. More than 50% of their hair was lost. So for them to have such a good response is quite good, particularly after many years. Very dramatic. So SALT score of 60.8 come down to 0.48 in 24 weeks. The other thing, they also found that if you use it for a bit longer, it was even better. So if you continue with it for about a year, it stabilizes and perhaps goes up even a little bit higher. There are other studies, particularly with baricitinib. I don't think the results are fairly similar, about 30 to 35%, but I think the cost effectiveness according to NICE was better with ritlecitinib. That's why this is the only drug we can give in the UK for alopecia areata. We can't give any of the other drugs. Let's look very briefly at the investigations we need to do. I always do these before we give it. Full blood count urinase and creatinine, that's a baseline for everyone. Hepatitis screen, because it can provoke infections, as we'll see later. TB screen does seem to be important. It does seem to aggravate pre-existing tuberculosis. And an unusual test, usually we don't do lipids for any other drug except acitretin or acitretinine. So for an immunomodulator to do lipids is unusual, but it is a drug which can raise lipids, so it's well worth doing. The side effects, most of them, the minor ones are, the usual nausea, vomiting, diarrhea, which is about 10 to 15%. Increased risk of infections. There is the possibility of acne. We call it JACne. So if you get it with JAK inhibitors, it's called JACne. I've had at least 2 patients with JACne. Both of them responded to topical agents. Both of them didn't have to stop their JAK inhibitor. And as we've discussed, it can increase the LDL cholesterol, which is the main risk factor for coronary artery disease. So you have to be really careful that LDL cholesterol is the one we measure. There are other more serious side effects. Zoster recurrence seems to be quite high. So that's again something we have to look out for. DVTs. Even in young people, DVTs seem to occur. TB reactivation we've talked about. Liver damage isn't that common. The ones we are most worried about in the UK are the major adverse cardiovascular events, MACE. So general consensus is if a person is above 60, you're much more likely to get these. So I would be very cautious about using a JAK inhibitor, somebody above the age of 60. You should explain to them that there is a possibility. If you look at the odds ratio, it's similar to TNF antagonists, and that's not that high. But still, it's something which we are still learning about. All JAKs for dermatology have been maybe about 5 years, maximum 10 years. So we don't have the long-term data yet. The other worrying thing is we don't know its association with malignancy yet. They still put it in the black box about the MACE and the malignancy in the UK. So again, it's something which we have to watch out for. Next is a case which I'll be showing you, and we'll see if you can get the diagnosis. So 6-year-old lad, born to Irish traveller community. No hair since born with hair, reasonable hair, but after infancy there's been no hair at all. And then developed these spots around the mouth, and the sister was also affected. This is not my patient, it's one of my colleagues from Chester who gave me these slides. So that's the boy aged 6 years. And that's the mouth. You can see those lesions. That's the sister. Yeah? Any ideas on the diagnosis? Could be ectodermal dysplasia, but what are these? What do they look like? They look like small. They look like papules. They look like cysts. It's common in Irish travelers. That's why I thought I'll put that in, because this is called atrachia with papular lesions. Yeah. So it's a genetic condition. I mean, this is the only family I know of who have it, but it's got these very characteristic features. It's autosomal recessive. You get this total alopecia, and they actually have normal hair at birth. It's after that they lose it, and then that doesn't come back at all. And they have this keratin-filled cysts everywhere, and all around the mouth is a common manifestation. They're otherwise normal. Everything else is completely normal. No abnormalities in sweating or the nails. All the other ectodermal structures are preserved. That's how you differentiate it from ectodermal dysplasias. And as I said, it's seen in Irish travelers, so there's some genetic mutation here. The pathogenesis is that the hair matrix cells undergoes apoptosis, and there's a decline in this BCL2. And because of this, there's a disconnection between the matrix from the overlying epithelial sheath. Normally, the matrix needs the epithelial sheath to form the dermal papillae. So when that's lost, they are disconnected. They don't talk to each other. So the hair bulb and the dermal papillae is stranded deep in the dermis. And that's why they form these small cysts. And they found that there is some genetic predisposition, this chromosome. It's supposed to regulate catagen modeling. And there are other missense mutation as well. And interestingly, there is a type of vitamin D resistant rickets 2A, which gives you exactly the same amount, same picture. So if you see this, you're better off looking for vitamin D resistant rickets as well. And that's from the IJT. Next question. What investigation is useful for patients with alopecia areata? I don't want the normal full blood count used in these LFTs. Can you think of any other investigation which is useful for therapeutics as well? Vitamin D, yes. Vitamin D is for almost any hair condition, even, hair loss occurring in female pattern, hair thinning, everything is important. Anything specific? Pardon me? Antithyroid, very good. That's very important. We know it's an autoimmune condition, so good association with antithyroid antibodies. Anything else? It's important to know this association because if you treat the underlying condition, actually sometimes the hairs may grow back. Focal sepsis, yes. It's rare, but recognized. So it's worthwhile keeping this in the back of our mind. It's probably not that common in India. I see it a bit in the UK, but it's not that common here. You're very close. Yes. It's celiac disease. It's TTG, tissue transglutaminase. So let's just look at the evidence or what there is to show that there is an association between the two. So if you look at alopecia areata, 1 to 2% of them will have TTG antibodies. It's quite a low percentage, but it is a well-defined association, which has been defined for nearly 30 years. So they looked at, in this series, they looked at nearly 250, and 3 were positive. And they didn't have GI symptoms. That's the thing. They won't complain to you that they have GI symptoms. You have to screen them and find that out. And the advantage is, in one boy, he had alopecia universalis. But when he had a gluten-free diet, it completely regrew. So that's useful. You're doing something non-medical, non-pharmacological, and you're getting his hair back. So it's a natural way of treating it. Some more associations between the two. This, again, 2003, you can see that a gluten-free diet resulted in complete regrowth of hair and improved gastrointestinal symptoms as well. That was from a general pediatric journal. And then another one, report of 2 cases showing a response to gluten-free diet. This was in Clinical and Experimental 1998. You can get reappearance of alopecia areata when you challenge them with gluten. So that's the best way to prove it. You avoid it, it comes back. You challenge it, it goes back to alopecia areata. And then a combination of both in a child with Down syndrome had complete regrowth of hair on getting a gluten-free diet. Another 13-year-old child, failure to thrive, alopecia areata, and celiac disease diagnosed on serology and complete growth on gluten-free diet. And finally, they looked at this. They found that if you have a serological positivity, it's usually about 1:305 in the general population, but in alopecia areata is 1:1 in 16. So about a third more than the general population. And 3 patients had hair regrowth on gluten-free diet. So if you have any suspicions of, probably the clinical way of doing it is, if a child or anybody comes to you with alopecia areata, ask them for abdominal symptoms. If they have any abdominal symptoms, just do a TTG. And if the TTG is positive, then think about a gluten-free diet, because that's a natural way of getting their hair back. And this was from Nature, which is actually one of the most difficult journals to get your paper into. It's really high impact factor. And they found that those HLA genes which cause alopecia areata also causes rheumatoid arthritis, diabetes, multiple sclerosis, psoriasis, and celiac disease. So celiac disease is genetically associated with other autoimmune conditions like alopecia areata. This is another patient of mine. So I'll show you the hair pictures first, and then you tell me if you know what it is. If you're not sure, I'll show you some more clues. So this child has been under my care since birth. I saw her when she was 2 days of age, and I know what this is because I've seen her from birth. So that scarring alopecia, and that's scarring alopecia. Any ideas what this could be? She's otherwise well, no rash anywhere else. I'll show you the picture I saw her. As I said, this was my very first clinic in North Wales, my first clinic, and this child comes. This is the same child. She was being treated for herpes, or treated as herpes. Any clues here? Female. Sorry? Yeah. So this is incontinentia pigmenta. You can see the sort of blastoid pattern there. Can you see that? Nothing much on the trunk. So these were vesicles, and the pediatricians were sure there was something infective going on. But looking at the pattern, I was fairly certain this was blastoid. I said, no, withhold everything. We'll just see her in a week's time. And then a couple of months, you can see that's the verrucous stage. You can see it, everything healed, completely gone. The only thing left was the scarring alopecia. So the reason you need to be aware of it is sometimes you will see these odd forms of scarring alopecia. You may examine the rest of their body and they may not have much. But I think we should look for these subtle markers. She may have some form of whorled pigmentation, or the parents may give a history of these blisters at birth. So that will give you a clue. Maybe it was incontinentia pigmentae, because when they come to you, all you'll be seeing is the scarring alopecia. But it's an interesting case, which I thought was good to present. This was a very recent study again, just came last year. So what treatment is as effective as a JAK inhibitor for alopecia totalis and universalis? So this was, yes, possible, but this was a RCT, it's a randomized controlled trial, and they found the response rate was almost as good as a JAK inhibitor. It was a French study. So one DCP, I would certainly agree with you, it's very good. It's quite hard to get hold of though. And in the UK, unfortunately in my department, everybody is sensitized. So we can't use it. So we have to send it to some other hospital, which is difficult. Any other systemic? Which ones? I don't know about monoclonal antibodies. This was another study. This is something we can use in India. That's why I thought I'll mention this. Cyclosporin possible. Anything else? Methotrexate. Would you give methotrexate on its own? This is interesting because they use methotrexate and prednisolone. And I think that is important. I've tried numerous people with methotrexate, but if you add that little bit of pred, it seems to work a lot better. And it is actually an excellent study. It's an RCT, double-blind, randomized. So it can't get better than this. And it was done fairly vigorously. I mean, there were about nearly 200 patients in this. And what they found was they had already had 16 studies before this. There was a meta-analysis of 16 studies before this. But what these people wanted to do is they wanted to prove that it works in alopecia totalis and universalis. So they picked up the worst patients, meaning severity-wise, and gave them either methotrexate or 20 or 25 milligrams. And then they gave this pred as well, 20 milligrams for 3 months, 15 milligrams for 3 months. I mean, I find that slightly on the higher side, but that's what they did. And if you look at JAK inhibitors, as I said, it's about 35 to 40%. And remember, they took only the totalis and universalis. In the JAK studies, they took up to 50. So 50% of hair was still there. This was much worse. So they took a worse cohort and got almost the same result after 12 months. So the learning point here for me at least is, this is what I give for most of my patients. This is my go-to combination. I would give them steroids first, try and switch it off. If it doesn't go away, I maintain them on a low dose of steroids, add in methotrexate, and give them 6 to 12 months. And I would say you may not get complete hair growth, but it's definitely better than many of the other drugs we use. And it's a lot more cost effective than using a JAK inhibitor, particularly in the UK. In the UK, a JAK inhibitor is £10,000 a year. Methotrexate, you can get away with a couple of £100. See, the cost is enormous, the difference. Okay, this one I've discussed with Tanuj and oh, well done. So, okay, I'm going to ask you more questions now. So, Murug's got the right answer. What hair treatment can contribute? We've already looked at PPD as well. That can give you that as well. But hair straightening, quite recently described, 2019. What they described was 2 young girls used hair straightening, and within 48 hours, AKI. They had vomiting and scalp rash, and they did the histology. It showed acute tubulointerstitial nephritis. So next question, what is deposited in the... Very good. It's an oxalate nephropathy. So calcium oxalate is deposited. There are various ways of getting oxalate in your urine. It's usually from something called primary hyperoxaluria. It's a genetic condition. It can have other causes as well. If you take a lot of ethylene glycol, vitamin C, or star fruit, that's unusual. But how does the oxalate nephropathy happen? How does it get to your kidney?
Use the glyoxylic acid.
Very good. So glyoxylic acid. So it's actually glycolic acid first. That's what's there in the hair straighteners. It reaches very high concentrations. It's absorbed through the skin, and that depends on the concentration and the duration of exposure. So the longer you leave it on the scalp, the more it's absorbed. It's safe they found that if you have a concentration of less than 30%, and if your skin pH is higher than 3, you're usually okay. But it's the glycolic acid which causes it. It then becomes glyoxylic acid in the liver. It's changed by an enzyme. It can be changed into 2 things. It can either become glycine or oxalate. Glycine is not that toxic, but oxalate is. And the oxalate is excreted in the kidney, and that's what's deposited in this calcium oxalate. Can any other ingredient give you a similar problem? Like glycolic acid, is there anything else that can give you an oxalate nephropathy after hair straighteners?
Ammonium and sodium thioglycolate.
Okay. Anything else? Anything? In fact, it's linked with this. Not PPD. It's formaldehyde. So it has been used in the past for hair straightening, but it's now banned. We can't get formaldehyde, at least for hair straightening anymore, at least in the UK or in Europe. But what happens is, when you have glycolic acid and you use very high temperatures, it becomes formaldehyde. And then formaldehyde does the same thing, and that causes oxalate nephropathy. So even though formaldehyde is banned, it still can cause problems in the...
In India they use it.
This was very useful to understand what's going on. So if you look at the hair straightening products, they have glycolic acid. When you have a low pH and there's sort of irritation of the hair scalp, or there's a break in the hair, the glycolic acid is absorbed. It becomes glycolate in the liver, and then if there are these enzymes, it becomes degraded to glycine. But if you have this enzyme, it becomes oxalate, and that's what gives you calcium oxalate crystals. Then there's probably a genetic variation. They find it more in Asia, so maybe there's some genetic predisposition as to why we get it more. And then look at the other way. So you have evaporation of formaldehyde from glycolic. So when you heat it up, the glycolic acid becomes formaldehyde. Then the formaldehyde-free products becomes absorbed, and it causes acute toxicity. So two different ways by which hair straighteners can cause problems. It can cause oxalate nephropathy and formaldehyde causing direct toxicity, causing tubular injury. So two ways by which your kidneys can be damaged. My last case, this is again one of my colleagues. Very, very interesting. 18-day-old child, rash on the sole, scattered on the face. I brought this up because she had a lesion on the scalp, which I'll show you. Also had lesion on the scalp and web spaces. No significant change since it started a week earlier. That was the nodule on the scalp. You can see it was a few years ago. I'll show you some more dates and you'll see how it's progressed. That's in the web space. Same day on the sole. This is what frightened us. Any ideas? I'll show you some more pictures of how it evolved. Maybe that'll give you a clue. So that's a week later. Started getting this on the face. Child was otherwise well. The lesion on the leg hadn't gone. So we did a biopsy then. Any differential diagnoses? Pardon me? These are nodules. They're firm. Yeah, they're ulcerated, but they're nodules. You're right. Even I thought, when I first saw the picture, when my colleague showed it to me, I thought, oh, is it a bulla? And he said, no, it's solid, and he had to biopsy it. Possible. Mastocytosis is possible. Anything else? It's unusual to get such a widespread mastocytosis. This is a special stain. It's congenital self-healing histiocytosis. So that's CD11 stain. So you get these papules, pustules, and ulcers in the neonatal period, and then it spontaneously resolves. I think it's called Pradzic-Kuchner disease. No systemic features at all. There are some very rarely who get systemic features, but most of them are completely well. They do say that it's best you investigate them. Just make sure there's nothing else anywhere else in the body. You do a systemic evaluation and repeat evaluation in 6 months. This is our child. That's 4 months later, 3 months later, completely gone. Nothing, no treatment, completely gone. And that's completely gone as well. So I hope these cases were helpful for you.
Thank you very much, Dr. Divakar. It's sometimes scary, sometimes so much of learning. And the hair dye and the hair straightener causing a kidney failure. My God, I think it's whoever it is, I think we should tell our family members not to go for hair straightening. The young girls particularly, very, very scary. It's very nice. I think the alopecia totalis and the new JAK inhibitors is promising. I think when it's going to come to India, I do not know whether it you started. I think very nice. I think good. Thank you so much. And please, yeah. I will just start putting my case today. I invite Dr. Sarveshwari to give a bouquet to Professor Paul Divakar Sudayan. Thank you, Dr. Sarveshwari. And presentation photo. Pilomatricoma and some other interesting hair related topics which will be very useful. Next slide. Sorry. A 15-year-old male presented with a large swelling involving the left side of the neck and another lesion over the left arm for 5 years duration. They were generally asymptomatic, but it was cosmetically uncomfortable for the young boy. Parents noticed a small skin-colored nodule over the left thigh which was excised when he was 7 years old. No details were seen. Subsequently, he noticed small skin lesions nodules appearing over neck and arm, and no intervention was done, and it was slowly growing to this extent. Next slide. Such a large lesion. He came to me one day. I didn't know what it was. Hanging, and this fellow was covering with a small towel, going to school with this for so many years. He was 15 years when he came to me, and this has been going on from the age of 7. Another lesion, as if some lymphoma, some kind of a plaque on the left arm. I could see these lesions almost as a thin skin hanging from the neck folds, and then like a tomato, it is going to rupture. So it was but no pain, no tenderness, no bleeding. There is fairly asymptomatic. Next slide. The skin nodule started increasing in size gradually over the last 5 years. The neck lesion started to hang, causing discomfort. Skin over the nodule appeared edematous and focally congested. There were a lot of red blood vessels are seen, superficial capillaries were seen. No ulcerations or bleeding from the lesions. Next slide. Ordered for a small X-ray of the neck and then the arm lesion, and you see the nice illuminated area of calcified boggy swelling on the lateral aspect of the neck. There were calcium deposits there, and again on the right arm the lesion was well defined. Nowadays we dermatologists ask for ultrasonogram and also dermoscope. It's becoming one of the therapeutic technology where we confirm the diagnosis before any kind of intervention is needed. Next slide. Dermoscopic findings, of course I didn't do, but there are literature says that you can see homogeneous yellowish white central area with the crown of vessels. Next slide. This is the surgery. I actually gave it to my plastic surgeon. He excised under general anesthesia. There were 3 lesions. Took an hour or 2 to proceed to completely excise. The scars healed very, very well. The patients were very, very happy. Next slide. What are the operating findings? So the cut surface through the largest nodule showed well circumscribed pale yellow firm to hard material with the diffuse gritty material. Probably shows that probably calcium was there. Cut surface of the other nodular fragment showed pale yellow well circumscribed with whitish granular and calcified areas. Next slide. The histopathology finding is very interesting. I've never seen histopathology like this. Skin with dermis and subcutaneous tissue were seen. Multiple circumscribed encapsulated lesion composed of proliferation of baseloid cells with abrupt tricholamel keratinization and transition to predominance of shadow cells with areas of infarction. Interspersed vascular fibrous connective tissue with some chronic inflammation, foreign body giant cell reaction with no cellular repair. There are 3 characters. One is the baseloid cells, the shadow cells, the foreign body giant cell reactions, or the chronic inflammation. This is the 3 highlighting feature of any histopathology of a pilomatricoma. Next slide. You see the classical features seen highlighted very nicely. Sorry, I got the slides 2 days ago. It's very shadow cells are here, and you see the calcification and the typical findings. Next slide. We made a diagnosis of giant pilomatricoma with multiple lesions. So this is the probable diagnosis we got. There are literatures. Anyway, next slide. Shows that also called calcifying epithelium of Malhebri, always called pilomatrixoma, is a benign adnexial dermal or subcutaneous tumor derived from the immature hair matrix cells. It was first described in 1880 by Mulberry and Chennaitis. In 1961, Forbes and Helvig coined the term pilomatrixoma. Next slide. This tumor typically affects individuals during their first 2 decades of life. Clinically, sometimes it is more commonly seen in females. It usually manifests a firm, deep nodule with diameter ranging from 3 to 30 millimeter, mainly on the upper body, most of the cases. Pediatric onset is the most common. There are a lot of literature showing 50s and 60 patients with pediatric age group being analyzed in the literature of pilomatricoma. Next slide. And we need to look, because if you see so many extensive large lesions, we need to look into their associations. Multiple lesions can be associated with the myotonic dystrophy, familial adenomatous polyposis related syndromes, Gardner syndrome, Turner syndrome, or Rubinstein-Tebe syndrome, and always these people, students, affected individual needs total screening for associated conditions. Next slide. Thank you. Next slide. This is with relate to Dr. Divakar's discussion on the very difficult cases of alopecia totalis and alopecia universalis. We in India, this tofacitinib is freely available. There are no guidelines to use. People give it for every conditions. We learned something from this use from the rheumatologist, and this is an interesting which I came to showed you last year in our meeting, and probably May 23 we did that. Next slide. This young boy of a 21-year-old male present with alopecia totalis and universalis of 1 year duration started with a patchy hair loss over scalp, progressed to involve the entire scalp and the body, had taken treatment with topical, intralesional steroid, Minoxidil, DNCB, DPCP, oral steroids everywhere, including you can see a small patch test was done for the contact irritants. Next slide. These are in November 22, I saw this patient was referred to me from a colleague from the Tanjore, and he had all the hairs are lost, and I didn't want to know how to proceed. At that time, a lot of few reports, but though it's not FDA approved, we started using it. Next slide. He started doing very, very well. Last time I presented, this patient developed very good hair growth across the body surface. All the hairs were white hairs. And then I subsequently continued the tofacitinib 5 mg, reducing the dosage to alternate days, and he developed good hair growth. All the hairs got pigmented very, very well. He's happy, but he's continuing one tablet on alternate days for the last 1.5 years. So I think, I don't know when we stop this, I think all the hairs might drop. We do not know. We will need to wait and see the literature finding whether this boy could complete his engineering studies and he got employed in an IT company. I think JAK inhibitors will definitely play a role, and the newer one which Dr. Divakar was telling us, probably that will be a better option than, because I do not know about the side effects of this newer molecule. I've got tofacitinib, as you listed, so many side effects are there. So we have to be very careful in starting, and regular monitoring is needed when tofacitinib is used in either condition, including vitiligo. I achieved very good results in certain cases of vitiligo, but this is an eye opener today, which Dr. Divakar has said. Probably we are waiting for the new JAK inhibitors. Next slide. Thank you so much. Yes, Divakar, your comments on this patient on alopecia, pilomatricoma, or?
I think pilomatricoma, my son has actually, he did a review of cases of myotonic dystrophy with pilomatricoma. So he is actually going to present it in Cambridge, I think. So that was an interesting association. I was not aware of it before that. And tofacitinib, our rheumatologists use it a lot, but we hardly use it. One of my colleagues has given it to a patient with dermatomyositis, but I personally don't have any experience with it.
Thank you. Anyway, we will invite when we discuss this topic with professors at the end. Thank you. We proceed with the next program, where spectrum of clinical hair disorders, as usual, session 2 and episode 3, Professor Murugasuntharam will take over this topic.
Good evening to everyone. Respected Professor Sir, my teacher, and all my seniors and teachers, my colleagues. Case number 1 is a 23-year-old young man with history of painful boils over the scalp, face, armpits and groin for the past 3 years. The boils over the face, armpits and groin settled over a period of time, but the boils over the scalp were persistent, and they also became confluent and formed painful tracts. He had taken treatment in the form of medicines like clindamycin orally, oral retinoids, and procedures such as cryotherapy, intralesional steroids, lasers, all without much improvement. So those are the tracts, huge boils, some folliculitis lesions also. So the histopathology was classical, lot of neutrophils, and a lot of fibrosis. Giant cells. What is this? Dissecting cellulitis. Yes. So dissecting cellulitis, also known as perifolliculitis capitis abscendens et suffodiens. I never used to get it right when I was a PG. Or Hoffman's disease, an inflammatory disease of the skin. It manifests as perifollicular pustules, keloids, nodules, abscess, sinuses that evolve into scarring alopecia. I haven't seen many cases of dissecting cellulitis. Only I think it's a third or fourth case I've seen. It also a part of follicular inclusion triad, hydrangeas suppurativa and acne conglobata. I think probably he had both, and they were treated by the oral retinoids, and but this dissecting cellulitis persisted, and very young boy, and I recently saw an article with an association with Crohn's disease, dissecting cellulitis with Crohn's disease. So probably I have to check, as Diva said, screen for celiac disease and alopecia areata. I should screen him for Crohn's disease. It was first described by Spitz in 1903. I think he's the one. No, he gave dermatitis folliculitis capitis, perifolliculitis conglomata. Hoffman was better. Perifolliculitis capitis abscendens et suffodiens. The pathogenesis follicular hyperkeratosis, follicular occlusion, retention of follicular products. Histologically, a lot of plasma cells, then dense neutrophils, granulomas, scarring and fibrosis. So the differential diagnosis, sometimes tinea capitis is very common in our country. Sometimes tinea capitis might look like this. The chirion may sometimes look like this, and many surgeons open it thinking that it is an abscess. Even dissecting cellulitis, they open it and they do surgery and make more scarring. Metastatic Crohn's disease, I only learnt now. Erosive pustular dermatitis, I think Diva had shown a couple of cases of erosive pustular dermatosis, sometimes may look like this. Although the abscesses are sterile, organisms like Pseudomonas, Staphylococcus, Propionibacterium, and Prevotella intermedia, I don't know about that, Prevotella, that's a new thing, could be there. So case number 2 is a 13-year-old schoolgirl who presented with patchy hair loss on the right temporoparietal scalp. Ignored as general hair thinning since childhood, but the patch became obvious as the hair grew in all other areas. No history of hair pulling habit, no history of smooth bald patches elsewhere in the scalp. This has been present for a very long duration, and I think probably they noticed only now when they started. Yes, Diva's right. See, the diagnostic features, you see only vellus hairs on dermoscopy. You don't see any terminal hairs. And see, the shape is not triangular. It is almost elliptical or rectangular. So this triangular alopecia need not be triangular. It can be rectangular, it can be elliptical. So I thought I would call this as congenital temporoparietal elliptical or rectangular alopecia. And the most important thing is you have to, identify and label it. Otherwise, somebody may give an intralesional steroid or do some cryotherapy, or they may even prescribe tofacitinib thinking that it is alopecia areata. So the only answer is hair transplant. But most of the people, they try to cover it with the long hair, and it has never been a therapeutic challenge. Case number 3 is an 18-year-old girl who noticed patchy thinning of left eyebrow hair after threading for the shaping of eyebrows. She's actually from the US, and whenever these people visit India, they go to the parlor and dentist, and they do all these procedures. No history of patchy loss of scalp because they are all cheaper here. Patchy loss of scalp hair. No history of hair pulling or hair rubbing habit, because sometimes when there is a loss of eyebrow hair, you also always take the history of rubbing of the hair, because there is something called trichotillomania where you rub it and remove the hair. So I asked for that, and there was no history of pulling or hair rubbing habit also. So you can see the thinning over there. And no signs of, but if you see carefully here, what does it look like? And see here, this is a very interesting feature, trichoscopic feature, which we have read in textbooks, but we have never seen it. Probably we have not very commonly seen this. What is the condition, and what is the what is this, and what is the trichoscopic image that you see? It's a very early alopecia areata. So you see the exclamation mark here very clearly, and this is the cootability, the tapering of the hair towards the root. You can see it very clearly. It gets narrowed, and then after some time, when the disease is severe, it gets cut off. Then you get the dysplastic or the dystrophic hairs. So very early, just to show the importance and the usefulness of trichoscopy to identify very early case of alopecia areata. Case number 4 is a 9-year-old boy who presented with a triangular patch of hair loss over the left temporal scalp. He also had history of nail biting and lip picking. A lot of children come with this lip picking. We often think that it is cheilitis, even though they don't expose to sunlight, or there is no history of allergic contact dermatitis. There is a lot of acquired cheilitis kind of presentation. So he had this patchy hair loss. But the hairs are all terminal, no vellus hairs. Even though the apex of the triangle is pointing towards the vertex, the hairs are all terminal, no vellus hairs, and you see the lip picking. The trichoscopy, the pull test was only 2 hairs per 20, and one was broken and one was this. You see this? Like as if the root sheaths have been ruptured. Trichotillomania, but there is no mania. This is trichotill. This child has got this playful hair pulling habit without any obsession or compulsion, because he was able to admit that he is pulling the hair. So it is trichotill and not trichotillomania. Very common in children, often associated with nail biting and lip picking. Sorry. And the absence of vellus hairs in the triangular patch rules out CTTA, because the very common differential diagnosis for CTTA is this trichotillomania, because these children pull this in the accessible areas. and that is usually the temporal area. The case number 5 and the last case is a 30-year-old woman who was very fond of visiting hair spas and beauty parlors. It's something related to Diva's case, Diva snippets. She presented with a profuse loss of hair and there was a history of hair breakage even with gentle combing. See, you can see the impact of the beauty parlors, perfectly shaped eyebrows and all that. I think she goes every day to the beauty parlor. And lot of hair breakage. This is a very simple, just put a visiting card under the hair and you can see the hair breakage and you can take a photograph and keep it for your records. Otherwise, this irregular length of hair may get unnoticed. And trichoscopy showed 5 hairs out of 20 and majority of the hairs were broken. As if I have wrongly mounted the hairs. So there's no root at all. They are neither dystrophic or dysplastic, but they are just cut as if they are cut with scissors. And further magnification shows this split. See here. But there are no nodes. When there is a split like this, breakage like this, you may expect trichorexis nodosa, but there are no nodes here. And the other 2 hairs also showed a split exactly in the middle of the shaft. And see here the fraying in the breakage. What is this? Trichoschizia. This is like a split mind, like you get schizophrenia. Trichoschizia is the exact split hair in the longitudinal length of the hair. So this trichoschizia due to these are all hair shaft weathering. So many hair shaft defects may be there. They are collectively called as hair shaft weathering defects due to this parlor procedures. As Diva said, of the numerous harmful chemicals in I was really surprised to know that there are more than 5,000 chemicals in one hair dye. So of this, PPD is the most notorious, and the second notorious is the sodium and ammonium thioglycolate, the glycolic acid and the glycolate derivatives, which convert into glyoxylic acid in the liver, and they only cause this acute kidney injury, oxalate nephropathy. And the hair breakage is because of this thioglycolates irreversibly break and damage the disulfide bonds. The disulfide bond, the hair is connected, interconnected. 2 keratin molecules are connected by either the hydrogen bond or the disulfide bond. The disulfide bond is the strongest bond in the human body, and that is broken and it is irreversibly damaged by this thioglycolates. And this causes continuous breakage of anagen hairs, the growing hairs, for up to 2 to 5 years duration. So whenever somebody comes, asks for a hair straightening or a smoothening, and now they have called it as keratin treatment. That is all. So all these are the same similar procedures with different names, and like dog spa, you have car spa, you have hair spa now. So the glyoxylic acid, that acute kidney injury which they were highlighted. Thank you so much.
Yes, Murugan, as usual, you have done a nice presentation and it's mind-boggling. I think you have to talk something on minoxidil. No?
Yes, sir.
New insights into the minoxidil.
Yes. So I think it was 1996 or I think late 1996 when I started my practice. Chief gave me 2 reference articles and said a lot of these hair patients are bugging me, and I don't have the patience to treat them, and you start dealing with these hair patients. And I took those 2 articles. So they were very sparse literature those days, and only Mintop 2% was available. The only minoxidil available was Mintop 2%, and nobody used to promote with this that Mintop 2%. And now I believe there are about 2,000 brands of minoxidil now. So 2%, 5%, 7.5%, 10%, and even 12.5%. So a lot of changes in minoxidil in the recent 2-3 years. So as we all know, we knew only minoxidil acts by only one mechanism of action was known to us, like it opens the ATP potassium channels, ATP dependent potassium channels, and causes vasodilatation, and that is why it was used as a antihypertensive drug originally. And but it was a weak antihypertensive, and when it was given for hypertensive patients, they also grew a lot of hair, and that is why, like any other drug in trichology, minoxidil also is a serendipitously discovered drug. So now we know there are so many other mechanism of actions, like it activates the ERK and AKT pathways. It activates adenosine 1 and 2 receptors in the dermal papilla cells, and that is why it is very useful in congenital hypotrichosis also. And it is very useful for anagen maintenance. It prolongs anagen phase by improving the growth factors like vascular endothelial growth factor, IGF-1, etc. There are we recently, about 5-6 years ago, they discovered the prostaglandin receptors in the hair follicle. So minoxidil also increases the prostaglandin, the E2 receptors production, and it acts favorably towards hair growth. And it also inhibits the lysyl hydroxylase. That is why it is useful in reducing the perifollicular microfibrosis. This perifollicular microfibrosis is the first event in the pathogenesis of androgenetic alopecia. So that is apart from being a vasodilator and increasing the blood flow, minoxidil acts mainly by reducing this loose concentric fibrosis around the hair follicle, and that is why it has become a very important indispensable drug in the treatment of androgenetic alopecia. And it suppresses the androgen receptor related functions, and it also increases the expression of vascular endothelial growth factor. It also produces neoangiogenesis and increases not only increases blood flow but increases neoangiogenesis and decreases catagen, and it is actually a proanagen and anti-catagen. Inhibits TGF beta induced apoptosis of hair matrix cells. It activates beta-catenin pathway in the dermal papilla cells. That is why it is useful in all the genetic disorders as well. So previously minoxidil was available only in the alcohol base, the propylene glycol base, which caused a lot of irritation, and most of the minoxidil hypersensitivity was attributed to the propylene glycol vehicle of the minoxidil. But now they have removed that. Lot of concentrations, as I told you, and this was really surprising. Somebody has used even 15% minoxidil, and clinical response was seen in 60% of patients, significant improvement. So now this propylene glycol vehicle has been removed and or maybe reduced in concentration, and they have used water, and they are using other nanoparticles and nano emulsion systems, and even a lot of lipid emulsions, and they are even using coconut oil emulsions. So a lot of improvement in the vehicle has come, and minoxidil usage has become very user friendly, and there is no dryness, there is no irritation. The allergic contact dermatitis due to the vehicle of minoxidil is reduced to a great extent. and there are not much information about the minoxidil sulfotransferase activity in this slide, but let me just brief about it. Now you have this Mintop booster. So this minoxidil is a prodrug. It doesn't act directly on the hair follicle. Minoxidil has to be converted to minoxidil sulfate by sulfotransferase enzyme, which is present in the scalp. So this there are a few studies stating that the minoxidil sulfotransferase activity is not adequate in some patients. So now they have come out with some drugs which can increase the minoxidil sulfotransferase activity, and the active formation of minoxidil into minoxidil sulfate is improved by that. So the minoxidil booster or the minoxidil sulfotransferase activator should be used 10 minutes before applying minoxidil. So it is slowly coming, and we need larger studies to believe that and to use it as a sustainable adjuvant in the treatment of androgenetic alopecia. So alcohol-free minoxidil, that is propylene glycol-free minoxidil, is now available, and previously it was not possible to prepare minoxidil in the alcohol-free base because they said it cannot be, it cannot stay in that, it cannot be solved. But now a lot of new solvents and preservatives have come, which is actually a boon to these minoxidil users. And oral minoxidil has now come, and Diva gave a beautiful talk in the previous meeting about this oral minoxidil, and that was the most important take-home message in that was it is not 2.5 milligrams as recommended for the men, but it is 4 milligrams. You have to give prescribe 1.5 tablet of this 2.5 milligram oral minoxidil which is available. So Diva said this 4 milligram minoxidil is supposed to be therapeutically beneficial in men, and 1.25 milligram of minoxidil in female pattern hair loss. So oral minoxidil is also very useful. It is available freely like tofacitinib, and we have used in a lot of patients and without much side effects. I haven't seen the only adverse effect with oral minoxidil is the facial hair, especially in women with 1.25 milligrams of oral minoxidil. But if you treat them intermittently, stopping it for a while and then restarting it, that adverse effect is also minimal. So all these are newer innovations in minoxidil. We have to wait and see for the good effects and the adverse effects. But we should really thank Dr. Reddy's for putting their mind and effort into this therapeutic aspects of trichology. And we should also thank Dr. Reddy's for continuously sponsoring our quarterly meetings and our conferences. Thanks, Dr. Reddy's. Low dose oral minoxidil. So I won't bore you with all these pharmaceutical stuff. Thank you so much.
Thank you, Dr. Murugasundaram, for a wonderful lecture. And as we invite our Professor Patrick Esdain for his comments and sharing of his knowledge.
So good to see so many of you have turned up in spite of the two important matches, cricket as well as tennis. Shows your interest in trichology. But you will agree we have had a very informative session in the past 2 hours or so. So a few words about comments about the talks. One is Deva's thing about hair dye. One of the things which is not mentioned is cancer of the bladder. This was reported. Those of you who use hair dye, a lot of people think it is only on the hair. Actually, for the next 24 hours, if you examine the urine, PPD is being excreted in the urine. And PPD is a carcinogen. So by constantly being excreted, it can cause bladder cancer. And the other point is anaphylaxis. In fact, it has happened many times before in our own circle of dermatologists. One of our colleagues, she had a collapse once after putting hair dye. Within 10 minutes, she collapsed, anaphylactic. She had to be rushed to Apollo First Med and then revived, kept there for 3 days, and she came out. After that, she stopped using it. Till then, she was very hesitant to stop. So it can happen, very serious anaphylactic reactions. And then in the West, immediately the doctor or the beautician will be taken to the court for compensation, And that is why they do the so-called prophetic patch testing, which is of no use at all. But still, they have to do it. If they don't do the prophetic patch test and the patient gets anaphylaxis, the court will go against this person. That was one thing. And then the other one is that so-called pigmented cosmetic dermatitis, we see so often. I'm sure all of you would have seen it. It's extremely difficult to treat or to satisfy the patient. That is the important thing. Even we feel it is better pressure, I'm not getting better. And sometimes it's not just black, it's a peculiar gray color. And that is why I think most of the South American cases, they call it ashy dermatosis. How many of those ashy dermatosis were actually pigmented cosmetic, we do not know. But here we do get it, and it's a difficult condition to treat. And all this is because you want to make your white hair dark. I still cannot imagine why people go to all this trouble, what Diva said, coffee and this and that, a regular vegetarian diet on the scalp. I was never bothered. I became grey quite early, late 30s, fortunately after my marriage. And many of my colleagues started using hair dye by the 30s. I wasn't bothered about it. Similarly, loss of hair also. I couldn't care less whether they had hair or not. But you'll see people so worried about hair loss, putting Minoxidil and this and that. Anyway, that's individual attitude, I suppose. And my only grouse against Murugasundaram is, at one point he had very black hair, and I was told that his mother-in-law had developed a nice formula from leaves. They were living in Annamalai, I think. And unfortunately, she went and mislaid the thing. He also didn't pursue. If only she had formulated that particular darkening thing, he would have been the richest person in Chennai just now, because it would have sold. I hope he will take up that research again. Then, of course, there were snippets. My only worry is that, as somebody pointed out, JAK inhibitors are being used left, right, center. What is going to happen in the future, we do not know. And very few people bother to go through that list that he gave of tests that you have to. Straight away they give JAK inhibitors, even to children. The results may be good now. What about the long-term thing? We have to think about that. Then, of course, he showed some cases, and this celiac disease, yes, about 3 months ago, I gave a short video talk, 10 minutes, on the cutaneous manifestations of celiac disease. I had mentioned about alopecia areata and that also. So it's worthwhile going into that. Then this incontinentia pigmentosa, the very first case I saw was not in India, because I did only my house surgency under Dr. Tambaya. When I was working there in Scotland, one day my chief there, Dr. Freenbell, he called me and said, there was a pediatric hospital near the main hospital. He said, go there in the evening, have a look at this baby in this bed, come and tell me what it is. I went and saw this baby. It was looking something like what he showed, a lot of blisters and all. No clue at all. I just started dermatology. So I thought it was epidermalized bullosa. Then he told me that this is classical incontinentia pigmentae. And that was the very first case that I saw. It's nice to see it again. Then, of course, this renal failure after hair straightening was an eye opener. A lot of girls, as you go and straighten their hair now, beautiful hair, which they go and straighten it. And this is because they break the disulfide linkage, one of the strongest bonds which holds the hair shaft together. And once you break it, may reform. But there was an article many years ago, I read a book on keratinization. The bond which reforms after you break it once is not the true disulfide linkage, it's a lanthionine bond, which is never as strong as the disulfide linkage, always a little weaker. So this is something which you have to keep in mind. Okay, after straightening, the next generation may be okay, but the bond which forms will be always weaker because it's not the original disulfide, it's a lanthionine bond. Yeah, this self-healing histiocytosis, a lot of these histiocytic tumors which are self-healing. Then, of course, Ravi showed us that pilomatricoma. I always preferred the old name, calcifying epithelioma of Malherbe. It's much more musical than pilomatricoma, which is very harsh sounding, you know. And that point about calcifying is very important. Many of them calcify. You can see the calcification seen there. And as I said, my grandson in Cambridge, he has collected a few cases, and he did present it at one of the conferences in Cambridge University. He was too busy, otherwise I would have asked him to show his cases here. He's writing his exam now. And this connection between this and myotonic dystrophy, and there's another connection. If you remember, about 4 years ago, we had our annual MCCM meeting. One of the cases was pilomatricoma. I think Stanley Medical or GH, somebody presented. That was a patient with the glioblastoma in the brain who also had pilomatricoma. We didn't know why it was there, and then the connection was that beta-catenin, which he talked about. The beta-catenin pathway is affected both in the brain and in the skin, and which is supposed to be responsible for the. The other thing was recently, Diva had attended the AAD meeting in Santiago, and he had sent me the proceedings. So one of them was this use of JAK inhibitors in various conditions, and he said in alopecia totalis results may be very good, but somebody said how long to give. He said you cannot stop it for at least a year, and even after that it must be very, very gradually reduced. Any abrupt reduction, the hair will fall off. This came out in one of the papers recently in the AAD meeting. So don't stop abruptly. And finally, we had Uruk's patients, his cases, interesting cases. The dissecting cellulitis. I was telling yesterday we presented it at the MCCM meeting, and I was telling them how, if you want good descriptions of some of these odd entities, you have to go to the old textbooks. The best description of dissecting cellulitis is to be found in Ormsby and Montgomery. It was first edition was 1954. Which I followed for my MRCP. Beautiful clinical descriptions. I mean, the treatment and all may be all right. And in fact, the treatment for dissecting cellulitis he has given is X-ray. And then 10% sulfur ointment and vaccine. What that vaccine is, we don't know. That was the accepted treatment. There was therapeutic bankruptcy in those days. But clinical descriptions, nobody could beat them when it comes to that. That's why if you want a good description, go back to the old books and look them up. I think that's about all, and thanks for the tips on. Yes, I do thank Mrs. Reddy's who have been with us throughout this our travel in trichology right from the day one. Particularly Joffe, Joffe is now not here, been transferred somewhere left. Been very helpful and useful in running. And I do hope that we'll have these quarterly meetings in future. There's been a big break. And above all, I do hope we'll have our international meeting. We had 3 meetings which are wonderfully organized and very much appreciated. We have trichologists coming from all over the world to attend those meetings. So congratulations to all the organizers. Thank you very much.
Thank you very much, sir, for your inputs. Professor Sambat, sir, please hand over a bouquet to Professor Patrick in appreciation, sir, and respects.
So I thank our Professor Patrick sir for being the lead kindly light for all of us. If you had, like without him, we would have just been all the time practicing, and you would have forgotten everything about dermatology. So thank you so much, sir. Thank you to all my teachers, for all of those who have come with, as Steve said, in spite of two important matches and a lot of other things. Being a Sunday evening, instead of spending time with the family, you have come here to learn trichology. I really appreciate. Thanks a lot. Thank you, Ravichandran sir, for accepting to be the chairperson, and thank you, Diva. We always learn. We continue to learn from sir, and then from you, and probably from Rohan also, I think. So wonderful, and we are really blessed to have this generation of dermatologists teaching us selflessly. So really thank you, and I thank Dr. Reddy's for organizing these events regularly. Without any, they give this support unconditionally, and thanks a lot, Dr. Reddy's, and we have arranged for cocktails and dinners. Please enjoy. Thank you so much once again, and thank each and every one of my teachers and seniors. They are all very good friends of mine, and they're all like great guiding spirits for me. So I really thank from the bottom of my heart, and I thank all the young colleagues. Please do attend regularly. Please join the Hair Research Society as members. You'll be learning, because you will learn the right way of practicing trichology, and you'll also be receiving the International Journal of Trichology, the only journal for hair. So I request all the young dermatologists to join the Hair Society and enjoy the benefits. Thank you so much. I think oral minoxidil is celebrating a birthday. So they request Chief to cut the cake.
This bouquet. Thank you.
Yeah. So for dinner and cocktails.